Thank you, Sri Priya, and good evening to all of you. Thank you all for joining back. Uh, Today it's a bit of a long session. We have got a lot of things to cover, and that's why we will straight away start. I am going to share the screen. Yeah, so this is part two. Today we are going to talk about some advanced communication procedures. Why I call them procedures? Because like any procedure, it is a skill. It's a communication skill, and there is an indication, and there is a usual uh, pathway or a standard operating procedure, and there's an expected outcome out of that procedure. Today we will be talking about communicating bad news. We'll talk about some of the models that are practiced. We'll talk about uh, why we should communicate bad news at all to the patient. From there, we will take a diversion. We'll go to collusion. We'll talk a little bit about that. Then we'll come back to communicating bad news. And this time we will see how to go about it. And last, a little bit about anger management. So why it is difficult to communicate bad news? Because we have to speak the truth. So essentially, truth telling is communicating bad news. If we remind ourselves that it is telling the truth to the patient, then a little bit of stigma in our mind regarding doing something bad goes away, because the word bad in breaking news makes it seem like a negative thing to do. Actually, it is breaking truth in the news. In our culture, we usually practice a non disclosure model. That is, even if a patient comes with the family, we ask the patient to go out of the room, and usually we will tell the bad news only to the family. That the reason being, in our culture, patient autonomy is not held to be very sacred. The family's right over the patient is given more importance. And therefore, in our culture, we say the patient does not come to us, it is the family which brings the patient to us. Plus, we may have our own particular reason for not disclosing the bad news to the patient. We may not feel confident enough to do that, or we may think that we are doing the right thing. The problem with this model is it can get into conflict with the patient who wants to know, because the patient has the right to know. And remember, the first cardinal principle of medical ethics is respecting patient's autonomy. And patient's autonomy means the patient has the right to know. The patient may want to know for various reasons, but if the patient wants to know, patient has the right to know. In some countries, they practice full disclosure model because they may be legally obliged to do so. These are usually the developed Western countries where patient autonomy is considered to be sacred. You cannot tell the family without the permission of the patient. Plus, you may feel that the patient has the right to know, so therefore, it is my duty to tell the bad news or the full news, the truthful news to the patient. But what about a patient who does not want to know? So, there also the conflict happens. Because remember, the patient has the right not to know as well. The patient may have many reasons why he or she does not want to know. So these two prevailing models, the non-disclosure model or the full disclosure model, both has its own sets of problems, because in both we decide how we want to communicate truth, which may get into conflict with the patient who either wants to know and has the right to know, or does not want to know and has the right not to know. Therefore, we come to a model called as the individualized disclosure model. And what does that mean? It means that we have to find out what does the person sitting in front of us, what does that person wants? Whether the person wants to know or whether the person does not want to know. And you will tell the truth only to the person who wants to know. So we have to figure out what category the person comes in. Somebody who wants to know, somebody doesn't want to know. And if somebody wants to know, then the next important thing is we have to figure out how much the person wants to know. Does the person want to know everything? Does the person want to know 69.8%? Or does the person want to know 52.3%? We have to figure that out. So we have to give the optimum amount of information, not less, not more. So before we go on to how to do that, let's talk about why truth telling is important, especially if the truth is pretty bad. First and foremost, if I knew that the disease I have is incurable, progressive, advanced, of course I will be upset. Of course I'll be angry. Of course I may go into depression. But ultimately, when I come to terms with it, I may then think, what should I do? What are the important things I need to do? I may think about settling the financial issues, telling my spouse my bank account, password, or I may give instructions about the affairs of my children, about their education, marriage. Right. In between the net connection got disconnected. Right. So there are a lot of things that I can do when I'm terminally ill, but still have enough physical and mental health to finish things that I need to do. So if you don't tell me the truth, I will never get around to finishing things. The disease may have given me a chance to do it, but you, without telling me, may end up denying me that chance. Then there's a question of hospital hopping and doctor shopping. See, I don't know what my reality is. You know. Since I don't know that my disease is incurable, it is progressive and advanced, since I do not know that, my expectation is I will get back to normal life and get back to work, and everything will be fine. You know that is never going to happen. And you can do what is realistically possible. You may be doing it, but that is not going to make me happy, because my expectations are way above my reality. And it is not my fault either, because nobody told me what my reality was. Therefore, as long as nobody tells me the truth, my expectations will be unrealistic, and whatever you may be doing to the best of your ability, it will not be satisfactory for me. And If your treatment is not satisfactory, I will lose faith in you and I'll demand my family to take me some other place. And when I demand that, then you lose the chance of helping me. Apart from that, my family suffers because they have to take me from one place to the other. Because everywhere I go, I have high hopes, then I start complaining about the poor services, then I demand to be taken some other place. So my family is carrying around me from place to place to place. They can't earn, and because the expenses are so high, they have to take a loan, they have to sell off things, and eventually my family will literally be on the road without a roof over their head. So such wastage of precious time, health, and resources happen because nobody told me the truth. That is not my fault. That is not my family's fault. It's just because we healthcare professionals did not make an effort to communicate the bad news to me. Telling this to my families does not help. I am the patient. Nobody told me. That is why I have unrealistic expectations. Another area is barrier in relationships. My family knows, but I don't know because you did tell me. So my family will pretend in front of me as if everything is okay. They may get overwhelmed once in a while and they will go to the father's room, to the bathroom and cry and wash their face with water and then come and pretend again as if everything is okay. And my body does not lie to me, even though the whole world is lying to me. My family lies to me, my friends lie to me, my doctor and my healthcare providers, everybody lies to me that everything is okay, don't worry. But my body does not lie to me. I know something serious is going on. I just don't know what, but I know something serious is going on. People are hiding the truth from me. I just don't have any clarity about what exactly it is, but I know things are not going on. And then I hate my relatives who are coming from far and wide, coming and standing at the door of my room with their hand over their chin, looking at me with sympathy. I absolutely hate it. I shout at my family members, why are you letting these people coming into my house? But they look helpless. They can't do anything about it. So all of these things are happening in the house. And a lot of time, precious time, is being wasted in playing a drama. When if you had told me what was the truth, I would have had a chance to hug my family and cry at least. My family would have had a chance to hug me and cry and tell me how much they love me. I would have had that chance too. But then I died, and you all put a garland around my picture, and then you wish you had some more time with me. What were you doing when I was still alive? Playing a drama? But these are the reasons why it is very important to tell the truth to the patient. And these 3 points you get once in a lifetime. You get only one chance. You only die once. So before you die, you have life. And within that life, you can do everything to close your life's business, prevent hospital hopping and doctor shopping, and enhance relationships rather than creating a barrier in relationships. That is why it is very important to communicate bad news. These 3 points should be kept in mind because telling the truth is not easy. It has to be worthwhile. Taking that effort and pain as a healthcare professional should be worthwhile. So please remember these 3 points. Coming to this part of collusion, we often have this experience of the family members coming and telling us, Doctor, please don't tell the patient. Basically, the family is trying to enter into a conspiracy of silence. They say, you communicate with us, you tell the truth to us, but don't tell it to the patient. Now, they don't mean harm, they mean well, because they are trying to protect their loved one from the harm they perceive the truth will bring on to the patient. Some people say, oh, the moment you tell the truth, my loved one will collapse. My loved one will cannot take the trauma of this. Some people say, if you tell the truth, he or she will stop eating and drinking and wither away and die. People have beliefs, and for them, their beliefs are real. So, as healthcare professional, when you're dealing with a family who comes and begs you, please do not tell, do not challenge their belief, because you only end up making them more frightened. Because if you say, no, 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 telling the truth is very important, they may think that you have an agenda and they may get more scared of you. And whatever good that you can do may not happen, because they will simply take the patient away. It is very important to understand that people have beliefs. For them, their beliefs are real. So do not challenge their belief. Instead, agree to collude. This is the first and most important part of collusion management, that is, agree to collude. Because when you say, okay, I will not tell, you are instantaneously reducing the anxiety of the family member. And then the family member will feel that you are on their side. And that is not enough. That is only the starting. The next step is to earn the family's trust. Just because you said that, okay, I agree, I will not tell the patient, does not mean they immediately start trusting you. To earn the family's trust, you have to practice active listening skills that we talked about last time. Because building up a relationship is how you earn the trust of the family. Another important aspect is how well and quickly you palliate the patient's physical suffering, provide satisfactory relief. You have a happy patient, you have a trusting family. Remember that you have a happy patient, you have a trusting family. You can do any amount of active listening, but if you don't use your palliative medical skills to quickly get the patient physically comfortable, relieve the breathlessness, relieve the pain, the moment you get the patient physically comfortable, the patient starts smiling, you have earned the trust of the family. So active listening skills and palliative medical skills together will help you earn the family's trust. Now they will start listening to you, and this is the good time to reorient the family. So this is the SOP. First, agree to collude. Second, earn the trust. Third, once you have earned the trust, reorient the family. Talk about the the chance of closing life's business, preventing hospital hopping, barriers in relationships, and many of these things the family will be able to relate as things that are happening to them in their lives. And gradually they will come around. Now it depends on your expertise, your skill. Remember, it's a skill, it is not a talent. We all, the more we practice, the better our conversion rates will begin. But it is often the case that despite our best efforts, you may have a family who resist the idea of telling the truth to the patient. So if you have tried to the best of your ability, but you are not able to reorient the family, do not push beyond a point, because if you push beyond a point, it will seem as if you have an agenda, and this will create friction between you and the family, which you just cannot afford, especially in our context. Because in our context, the family brings the patient to us, not the other way around. If you have tried to the best of your ability, there is no shame in failure. So be prepared for failures. As I said, there is no shame in failing. The only shame is in not trying. Therefore, whenever you encounter collusion, practice collusion management in the SOP that we just talked about. Agree, earn the trust, reorient, and once the family gets reoriented and say, often they say, okay, but we can't say, doctor, can you help us out? So in that kind of situation, I offer my services. I say, okay, I will talk to the patient. And I also tell them that if the patient does not want to know, I will not impose the information. I will proceed only if the patient wants to know. So in that way, with the family on my side, I will proceed to communicate bad news to the patient. Otherwise, not. And that might throw up a bit of a challenge once in a while, where the patient is adamant on wanting to know, and the family not yet convinced about the idea of telling the truth to the patient. So I don't tell a lie to the patient. I usually say, I need more information regarding your situation. I will come and talk to you once I have enough information. Now, that is not a lie, because I may have all the medical information. The information that I don't have is whether the family will agree or not. That information I don't have, because that is something in progress, that is under evaluation, whether the family will agree or not. So basically, one has to work in a bit of a gray zone and buy time, and hopefully we work with the family, and you will realize that as you practice the situation more and more and more, your conversion rates improves. But remember, the best communicator in the world will never have 100% conversion. They will have plenty of failures. So collusion management and failure go hand in hand. So don't worry if you have a family who does not agree. You try to do the best possible for the patient in all other possible way. And often the family agrees, then you can proceed to communicate bad news to the patient. Now, here is a globally practiced SOP called the Spikes protocol. Is setting up the interview. P is perception. What does the patient know? Remember, in our previous session in history taking, we talked about finding the patient's insight. What does the patient know? By asking question, what did they tell you? What was the report? And that kind of things. Obtaining the patient's invitation, we will find out how to do it. And once we have the patient's invitation, that is, the patient clearly tells you, yes, I want to know. That's invitation to share the knowledge. And you share the knowledge honestly, without medical jargon, in a language that is easily understandable. And as is to be expected, there would be emotions. And even if somebody is very stoic, remember, there's a lot of emotional turmoil going with it, even if somebody is not showing. Mostly, people will express their emotion. And you have to learn how to deal with it. And once you have dealt with the emotion, then you can talk about the strategy. what can be done, what cannot be done, how it is going to be done, etc., etc. Then you can close the interview by summarizing. So here is Mr. Bharat. The reference letter shows that he is a 60-year-old gentleman. The reference letter to you. The patient has brought a reference letter to you, and the information contained in the reference letter is it's Mr. Bharat, who is a 60-year-old gentleman. He had an abdominal discomfort and weight loss of about 2 months duration. The local GP referred him to gastro at the city hospital, where a radiological diagnosis of a mass lesion stomach was done. Histopathology showed carcinoma stomach, and exploratory lab showed multiple peritoneal metastasis. So the abdomen was closed without any particular intervention, and the patient was referred to you for symptomatic care or best supportive care. And the patient is sitting in front of you. So this is the reference letter that you have received. So if you talk to the patient, so let us hear what the patient says. You have asked the patient with an open-ended question. So tell me, what brings you here? Tell me. So the patient says, I have had gas since about 2 months. So I went to my nearby doctor. He gave me some gas tablets. I took it for about 1 week, but there was no relief. Then he took an X-ray of my stomach. And after that, he gave me a letter to see the gastro doctor at the city hospital. Okay, then what happened? The gastro doctor did a scan and a tube test. And after that, they told me that a surgery was needed. I didn't have any money with me at that time, so I went back to my village. And it took me some time to collect money. And once that was done, I contacted them. They gave me a date for the operation, and then the operation was done. After the surgery, they gave me this letter to come and see you. So this is a typical history that a patient may give. But this does not tell us what does the patient understand, what is the patient's insight. Therefore, the same history we can take in a different way by digging for more information. So you start with an open-ended question. So what brings you here? Tell me. Patient says, I have had gas since about 2 months duration. So I went to my nearby doctor. He gave me gas tablets. I took it about for 1 week. There was no relief. So again went back to him. Then he asked me to take an X-ray of my stomach. And then he, wait. Did he tell you why the X-ray was needed? No, I don't know. Okay, then what happened? What was the result of the X-ray? What was in there? I don't know the results. He just looked at the X-ray and he said that he will give me a letter and I should go and see the gastro doctor in the city hospital. Okay, then did he tell you why he was referring you to the gastro doctor? Well, I guess for better treatment. Okay, go on. So there the gastro doctor did a scan and a tube test. So what was the result of the scan? Did he tell you? Well, he said something and I didn't understand what he was saying. I don't know. Okay, and what was a tube test about? That also they said that there was something and he said some surgery was needed. But did they tell you what was the result of the tube test? They said something, I don't know what was that. So they were saying it in English, so I don't understand. Okay, right, fine. So then what happened? They said that I needed a surgery. I did not have money at that time, so I went back to my village and it took me some time to get the money arranged. So once that was done, I called them and I got a date, and then a surgery was done. And then after that, they gave me a letter to see you. But what about the surgery? I mean, what did they tell you? What was the surgery all about? Well, after surgery, my gas problem is gone, but I'm not feeling better. I'm getting tired each day. I'm not, you know, the same old me. Okay. Did they tell you why you are being sent here. Well, for better treatment, I mean, they said that rest of the treatment will be here. So when you dig, you realize that the patients have a lot of blank spots. They don't know a lot of things. They may know some of the things which are right, some of the things that they think is totally off track. I'm sorry about the overhead announcement. So you would have realized that there are a lot of areas that the patient has no idea. There are some areas where patient has probably right ideas, and there may be some areas where the patient has totally wrong ideas. So the importance of asking a detailed history is to find out what does the patient know about his or her own condition. Now, this is very important for us to keep in mind. So before you proceed, you need to do a pre-procedure preparation, uh, up to date yourself on the patient, allocate a dedicated time. Some doctors prefer to communicate bad news in the morning when they are fresh. I prefer to do it in the evening because if I'm doing it in my OP area, the OP area is usually quite calm and quiet, and as a result, uh, there is much less of distraction. I am usually free for the day. In my room, I usually have enough chairs to sit, paper cups and water and tissue because often there is a bit of crying. And of course, practice active listening skills. So sometimes the patient themselves may, without any effort on your side, will ask, Doctor, what is my problem? Can you tell me what is wrong with me? But there might be a patient who does not ask you actively. So you need to know. For that, you do an exploratory jab. Mr. Bharat, you told me you continue to feel tired. Do you wonder why? Do you want to know more about your disease? Yes, I do want to know more about my disease. So, when you explore, you can bring out a patient who may not have articulated that he or she wants to know. But when you make an exploratory statement or a question, then you give the freedom to the patient to ask if they wanted to know. At that point of time, you give a warning shot. If the patient themselves ask, what is wrong with me? What is the problem with me? You can give a warning shot, or you explore. And if the patient says, yes, I want to know, at that point of time, give a warning shot. And what exactly is a warning shot? An example, Mr. Bharat, if it is something serious, would you still want to know? The purpose of a warning shot is give a hint to the patient that something is serious in front of me, and this will give a chance for a patient to either go back or come forward. The other important purpose of a warning shot is it suddenly makes the atmosphere more serious. Till this point, the conversation was casual. From the warning shot, the whole atmosphere becomes more serious. In Hindi, I would say, Mr. Bharat, अगर बात कुछ सीरियस है तो भी क्या आप जानना चाहेंगे? In Malayalam, I would say, Mr. Bharat, കാര്യം ഇത്തിരി സീരിയസ് ആണെങ്കിലും അറിയണമെന്നുണ്ടോ? So it is very important that we keep it precise. There is two parts to it. If it is something serious, and the second part is, would you still want to know? So You have to practice how you phrase it in your own language, because it should come naturally. It should not come unnaturally. So you have to be very clear how you're saying it, what are the words you are going to use it, so that you keep practicing this so it comes naturally when it is a real patient situation. You can practice it in front of a mirror or without a mirror, but the important thing is there should be no confusion about what you're trying to convey. So once you have give a warning shot, you may have a reaction like this: no eye contact. No eye contact means the patient does not want to hear. Sometimes the patient may give an excuse: you give me this medicine, I'll come back after 2 weeks. Or the patient may deflect it, tell it to my children, I don't want. So something like that, if you see a body language like that, do not proceed. However, if you see a body language like this, eye contact, no confession, and the patient says, yes, I do want to know. Even if the patient is not saying something specifically, if the patient makes eye contact and looks at his study, that means the patient wants to know. So in individualized disclosure model, the first important thing was we have to identify whether the person sitting in front of you wants to know or not. Warning shot is the tool with which you differentiate a person who wants to know or not. So once you have a patient whom you have identified as somebody who wants to know, no confusion. This person looks into your eyes and says, yes, I want to know. There is no confusion. You can now proceed. So how do you proceed? You tell the story of the patient to the patient from the beginning, and while you tell the story, you fill in the blanks. Remember, you have previously, by taking a detailed history, not only found the patient's story, you also found the patient's insight. You know which are the blank spots, what are the areas that the patient does not know about his medical condition. So now, as you tell the story, you fill in the blanks. And as you fill in the blanks, as you proceed with the story, you gradually escalate the information. And while you are doing this, your focus should be on the patient's body language. Example, if the eye contact is maintained, you continue the story. If the eye contact is gone, you pause the story. Because it is possible that the patient has received new information and may need some time to digest this new information. Maybe a few seconds. At that point of time, the patient may not look at you. So once the patient again makes eye contact, then you can restart the story. If the eye contact is lost and it's a long pause and you don't know what to do, you can break the long pause after you have given sufficient time. You can break the long pause by asking a question: do you want me to proceed? Or do you want to know more? So this will break the spell, and then you will have a patient who will look back into your eyes and says yes, or look back at you, then you can proceed. Or if the patient continues not to look at you, then that means the patient had enough, at least enough for today. And that is how you figure out how much information you are supposed to give. If the patient is no longer seem to be interested to know more, you do not give more information. So that is how we figure out the optimum information that individual needs. So individualized disclosure of truth. We disclose only to the person who wants it, and we give only as much as the person needs it. So here I will do a small role play. Mr. Bharat, you have been suffering from gas since about 2 months, and you said that your local doctor gave you some gas medicines, which I think you took for about 1 week, right? And you said that you did not have any relief. And you said that when you went back to him, he asked you to get an X-ray done. Well, the X-ray showed something like a shadow. And to know more about the shadow, he referred you to the city hospital. So you can notice that I have filled in the blanks with words like something like a shadow. And in the next sentence, I have escalated that information. It is no longer something like a shadow, it has become shadow. X ray showed something like a shadow, and to know more about the shadow, he referred you to the city hospital. Oh, I didn't know that. Well, in the city hospital, your gastroenterologist did a few tests on you. So, one of that was the scan, and the scan showed something like a tumor. And to know what this tumor was, they did that tube test you were talking about. It's called endoscopy. And the tube test was done to see if your tumor was something like a cancer. Do you mean to say that I have cancer? I'm sorry. Yes. Mr. Bharat, do you want to know more? They had operated and removed my cancer, didn't they, doctor? I'm sorry. When they opened up your tummy, they found the cancer had already spread all over. They could not remove it. They lied to. Now you see the emotions are coming. So most often you will have people breaking down in tears at some point of time. And sometimes it may not be tears, it can be anger. They lied to me. So this anger may be towards the family members as well. Often they understand the family has been lying to them. So sometime at a later date, you may have to make the person understand that the family member lied because they love him and did not want to harm him by sharing this information. So that is how you kind of calm down a patient who is angry when you communicate the bad news to them. But whether they are crying or whether they are ventilating anger, what we have to do is don't do anything. Don't say anything. Don't do anything. Just be with the patient. At best, you can provide a gentle human touch, a momentary touch, nothing more. Now, this is something which is very hard for us doctors because all through our training, we are trained to do something. Nobody taught us how not to do something but just be with the patient. Please understand what you are doing now by just being with the patient is a psychological therapy. By allowing ventilation of emotion, you are providing psychological relaxation. If you do not provide this, their emotional state will never get relaxed. So just being calm, just being there, don't divert, but don't look into your mobile phone, check your WhatsApp, don't scribble notes in the case sheet, don't do anything. This is the time when you have to be 100% there with the patient, not focusing on anything else, just 100% on your patient. Keep your mouth shut, don't do something, just be there. This will help the patient ventilate, and once the emotions are ventilated, then the patient's rational brain will start working. Otherwise, it will not. So once the patient has ventilated and has calmed down, which will take about 1 minute at the most, maximum two. It doesn't take a long time. It's about just being patient for about a minute. And then be prepared for some questions. And remember, some of these questions can be tricky. And when people say something with emotion, for example, I'm so scared, I'm so worried, am I going to die? How much time do I have, doctor? When people ask this kind of questions, do not assume why they are saying that. Do not assume. Just ask them, why did you say that? And then the patient may say something like, my daughter's marriage is fixed and should I prepone it? So here is a patient who wants to plan, but the same question can be asked by the same patient or another patient. Doctor, how much time do I have? And without assuming, if you ask, why did you ask that? The patient may say something like, why did God do this to me? A totally different response. Remember, the question was the same. The reason why the patient said was different. So, two people, two different reasons, 100 people, same question, 100 different reasons. So, never assume, get the skill of asking why. And once you have taken care of all the emotional distress, once the emotion has subsided, now we can talk about what is possible, what is not possible, and what we can realistically do, and always, come to a decision by consensus, a participatory decision making. And remember, never give false hopes, but always finish with an achievable hope. So all those things that we talked about last time about history taking 2.0, adding active listening skills, you just use all of that in communicating bad news. Now, so we have come to the end of that. Now, coming to our day-to-day anger situation in the clinic, I would like to distinguish between anger situation in our day-to-day clinical practice from a law and order situation in our clinical practice. An example of a law and order situation would be a mob attack. We have been trained how to use a stethoscope. We have not been trained how to use a lathi or a gun. So those are the training that the law enforcement agencies get, and they are good at it. We are not good at it. So when you are confronted with a law and order problem, run away from that place with your life. That is not the place where you can do anger management. Similarly, if you are dealing with somebody who's under the influence of alcohol or other substance, you can't reason with a person under the influence. And if that person is getting violent, just walk away, because that is a law and order problem. What we are going to talk about here is that angry person shouting loudly outside your OP or outside the ICU or inside or outside the emergency, and how we need to manage that before it becomes a law and order. First of all, understand what exactly is anger. It is an emotion, it's a negative emotion. and it consumes a lot of energy to get angry and to stay angry. When was the last time you got up in the morning and said, I haven't been angry in a while. Today I'm going to get angry. Have you ever thought of that? Please understand, nobody likes to get angry. It consumes too much of energy. And it's a very, very negative, exhausting experience. People get angry because a lot of stress builds up. The beginning of the stress may not be even inside the hospital. It may be at home, it may be at road, it may be outside the hospital premises, then inside the hospital premises, then eventually outside your OP. So many things. Plus, on top of that, they are sick, they are not well, or their loved one is sick, their loved one is suffering. All of these negative things, the stresses, all builds up, and then it bursts out in the form of an angry reaction. Remember, the person who is getting angry, it is just a symptom of extreme stress that the person is experiencing. Some person may cry, some gets angry. Often we don't think about it. Why is this person getting angry? Nobody likes to get angry. But we can easily identify somebody who is angry. You see their facial expression. There's a lot of anger. The voice, the volume of the voice would be very high. And the tone of the voice would be very, very, uh, what do you call, sharp. And the content may have a lot of expletives. It may have a lot of bad language. And the person, there is so much of adrenaline, the person cannot calmly sit down and get angry. The angry person is usually standing or pacing around because there is so much of adrenaline, the person just cannot sit down. So, this is a hallmark of somebody who is extremely angry. So, we have to think of what are the ways where we can make this person more angry. How can we make him more angry? One, any kind of confrontation, arguing with them will make the person more angry. Or if you are trying to explain or give excuses, all of these things can make a person more angry who is already angry. Sometimes, even if you apologize, that apology may make the person more angry who is already in a big rage. So, anything can become a confrontation. And often we don't understand our body language may become a confrontation. We'll talk about it later. Another form of increasing anger is if you ignore this person. Earlier, I said any kind of confrontation will increase the anger. I'm also saying that if you ignore this person, if you are feeling scared and you do not make eye contact, you turn your back towards this person, that will come under ignoring this person, and that also will make the person more angry. So, damned if you do, damned if you don't. But there is a way out of it. You should neither confront nor ignore an angry person. Many a times we don't understand our body language, which can make the person more angry. That is why it is most important to understand how, what is the correct body language to be adopted when we are dealing with anger. As I said earlier, somebody who's very angry cannot sit down. There is too much of adrenaline for that person. That person just cannot sit down. That person will be standing or pacing around in severe anger. And you, as a doctor, if you are sitting there, that difference in body position creates a hierarchy, which your body is telling the body or the brain of the angry person that I am superior to you. That is me, the doctor, I am superior to you. Just the fact that you're sitting will be a confrontation. in the brain of the angry person. So, what you need to do, you have to show equality, which is a very positive body language, by standing up whenever you are in front of a person who is very angry. And then remember, a slight kyphosis. Whether you're sitting or standing, a slight kyphosis shows respect. You are telling this person, I am here to listen to you. So that message from your body goes into the brain of the angry person. And keep your hands where the angry person can see them, because you are conveying from with your body language that I mean no harm. I am not a threat to you. You don't have to be afraid of me. So these three things you put in place. The three very positive body language, because your body is going to do the talking. You are just going to keep quiet. The another important area is your face. You make eye contact with the angry person and you are showing, you are conveying, I am not scared of you. I am confident. This way, you are not ignoring the person. You are showing, I see you. I am not scared of you. I am confident. But at the same time, don't smile, keep your face serious, and you are showing that I take you seriously. I don't think you are a joker. I think you are to be taken seriously. And we learned in active listening how to encourage a person to talk by nodding your head. But here, do not make sounds like aha, go on. Don't make sounds, just nod your head. So, these two things, your body, position, posture, hands, and your face, eye contact, serious face, and nodding your head, all of these things are neither confrontation nor ignoring the patient. So you're not saying anything with your mouth, but you're saying everything with your body. And this allows the angry person to ventilate. Remember, it is just an emotion. It is not something the person chose to do when he or she got up in the morning. The person is full of this negative emotion and desperately wants to ventilate it. You become the medium through which the person ventilates. Just like you do an ascitic tapping, and gradually you allow the ascitic fluid to flow, and gradually the tummy, distended tummy, becomes deflated and becomes comfortable. Similarly, somebody who is severely angry, you do a psychic tapping and you allow the anger to flow in a controlled manner. And once you have adopted this and you have practiced this, you will see the anger gradually decreasing. Again, it doesn't take long. It will take about a minute or two. That's all. Because it is very difficult to sustain anger without either confrontation or ignoring. You have cut off the fuel supply. You have cut off the fuel supply for sustained anger. And then you will see visibly how the volume of the voice is coming down, the tone of the voice is becoming softer, and the quality of the language, the expletives and the very, very uncivilized words, they start coming down. And then you will see that the patient is still angry, but now is most of the time complaining in a more civilized manner. And once the severe anger comes down to the simmering level, at this point of time, you can offer to talk while sitting. I want to know more about this. Can we sit down somewhere and talk? So don't give an offer, don't give an invitation to sit and talk in the beginning. that will be counterproductive. Offer to sit down and talk once you have reduced the high anger to a simmering anger. And from reducing high anger to simmering anger, you don't have to open your mouth. You just allow your body to convey, you just allow your body to talk. You don't have to talk. So once you have reached this point where you have now finally opened your mouth and you are saying, I want to know more about this, can we sit down somewhere and talk? Then you continue helping this person ventilate their emotion. Now, instead of standing, both of you are sitting and you have a slight kyphosis, which is conveying that I am here to listen to you. I want to know more about this. And maintain eye contact, keep the face serious, keep nodding your head so that this person can talk, 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 talk. And by talking, the person keeps on ventilating whatever anger is remaining inside. Once all the anger has been expelled out, usually you would find that the patient apologizes for creating the trouble to all of you. Now, this is my personal experience. Whenever I have dealt with it, usually the angry person ends up apologizing to me for creating the trouble. But please understand that people sometimes get angry for very, very genuine reason for problems at our end. So if you find something like that, offer a solution if there is a solution. Offer an apology if it is really merited. But do not apologize for the sake of apology because nobody likes a fake apology. Apology has to be sincere, and sincere apology should be given only if there is a merit to it. Don't give apology just for the sake of it. Example, thank you for bringing this to our notice. We are very sorry you had to experience this. So here we are expressing apology. And that was an example. You can have another example without an apology. Thank you for bringing this to our notice. This is what we will do. And you tell them what you're going to do so that something like this doesn't happen again. So here we are thanking them without an apology. Previously, we thanked them with an apology. Take home points are when it comes to collusion, the trick is listening to the family, having the family on our side. Now, among the three communication procedures we talked about, collusion management is the hardest. It really takes a lot of skills and sometimes years of practice for real good conversion rate. But I assure you, the more you practice and do not get bogged down by the failures, keep practicing, and eventually your conversion rates will improve. It's just a matter of course, I can't talk in detail about how we do about it. It's basically we partnership with the family in a way that the onus of dealing with the problem is together, and we together try to find a solution and reach a point where the family finally agrees that perhaps it is better to convey the truth to the patient. As far as communicating bad news is concerned, our role is only as a facilitator of information. The patient decides whether they want to know or not, and the patient decides how much they want to know. We just have all this information, and we are just facilitating the flow of information in an honest and truthful manner. Remember, whether it is crying or anger, ventilation of emotion is not a waste of time. It is a very, very important therapy. Unfortunately, this is not taught to us as part of a regular medical training program. As far as anger management is concerned, among the three procedures we talked about, it is the easiest skill to master and practice. Basically, it is a non confrontational, active ventilation of emotion. And as I said, it's an easy skill to master. So with that, I come to the end of my session here, and I will stop sharing. Thank you.
Thank you, Dr. Biju, for the wonderful session as always. We'll take up a few questions before case presentation because this is a very, very important topic, very important skill to learn, the most important skill to learn in palliative care. So we can take up a few questions. You can either unmute, raise hand, or type it in the chat. Yes, Dr. Nethi, please go on.
Thank you for your talk, sir. Sir, I have just one doubt. So, like in cancer patients, most of the patients, are actually, talking, and cognition is not such a concern in most of the cases. But like I work in a rehab setup, so there most of the cases that I see is these hypoxic ischemic encephalopathies, where they are mostly in comatose. So I encountered this condition where the family member of that person, of the person who like of the patient, doesn't want me to reveal the diagnosis to the spouse, especially in the cases of females. They don't want me because first of all it's an acute, like in most of the cancer patients still they would be knowing the diagnosis. It'll take time to settle in, but in the cases of these patients that I see, all the brain injured patients, it's more sudden. Initially they are all in a stage of denial. Acceptance comes in very late, and most of the time they say that they request that this diagnosis, because the husband's concern is whether my wife will be okay and whether she'll be able to take care of the kids. And the patient's parents don't want me to tell it to the husband as to what the prognosis is, and I very well know what the prognosis is in most of the cases. So how do I communicate in such scenarios?
Uh, Thank you, Dr. Nidhi, for your question. I just need some clarification.
Yes,
The patient in this case is who?
the patient is suppose a female who
Okay,
has,
and the patient is comatose.
yes,
And who is asking you not to reveal the
her,
diagnosis
her
to
parents
whom?
her parents are asking me not to reveal the diagnosis to her husband.
To the husband.
Yeah,
Okay, and the husband
basically
is
they want me to say that the prognosis is still good.
to the husband.
Yes.
Okay, and what does the husband come and talk to you?
The husband is coming and asking me that all that he wants to know is whether she'll be able to take care of the kids.
Okay, right. So this is a classic case of collusion where
Yes.
one party is trying to enter into a conspiracy of silence with you so that you do not reveal the truth to the third party, that is
Yes.
the husband.
Yes, sir.
And husband comes and asks for some truthful discussion with you,
Yes.
and now you are in a fix, right?
Yeah.
So this is what exactly what we were talking about, which is collusion. And for that, it depends on what is the power play here, because for one, you can of course try to manage collusion with the young with the lady patient's parents who do not want you to discuss this with the husband. And the collusion management in this kind of this particular situation that you are talking about would, I guess, be relatively easier, because here you are not in the situation of talking to the patient. It's the husband, and husband has in our culture some rights over the wife. So it is a matter of discussing with the family, with the young lady's parents, about the husband is saying uh, that I just want to know whether she will be healthy enough to will she get back to taking care of the kids. Uh, I wonder what we can tell him. Ask the parents. Let the parents think, and you frame a question in such a way that you make them realize how difficult the situation is, and they may say, no, no, you tell him that, you tell him this. So next time you ask, so he said this, So what do we tell him now? So basically you incorporate them with your existential problem and reach a situation where they'll eventually say, okay, you tell him, right? So that is where the skill lies in collusion management. This is just a short of how we go about it. But for every patient, for every situation, we have to deal with the situation on our own. I can only show you the signpost. This is the direction we take. How you deal with the pebbles, the stones, and the rocks and the mountains on your way is entirely your personal journey.
Okay.
And I wish you well.
Yeah. Thank you.
Most welcome.
Is there any other question? Or I think we'll start the case presentation and then we'll take further questions. Shripriya?
Yes, ma'am. Sure.
Dr. Resi, are you there?
Yes, ma'am.
Yeah, please.
Good evening, everyone. Today I'm going to present a case on oral cancer. My name is Dr. Richard Mero, dental surgeon, Naga Hospital, Authority, Kohima, Nagaland. Patient biographical data, age 45 years age, gender male, diagnosis, local advanced oral cancer, T4B, very advanced local disease where tumor invades pervertical fascia, in case carotid artery or involving mediastinal structure, heart structure, esophagus, and cardiac nerve, and two or three nodes are affected, and more cancer has not spread to the distant site. Next slide, please. Next, presenting complaint. A 45-year-old patient was admitted with presenting complaint of oral cancer since 1 year, 3 months, 9 months, 2 months ulceration over skin, cheeks, and discharge, no pus, 2 months unable to chew, eat, pain, with throbbing types and an episode of pain triggers during the investigation. 1 month mixed pain radiation to the end and temporal region with pain score 9 by 10. 1 month insomnia, 1 week constipation. Next slide. History of illness. Patient was apparently well until December 2020, when he initially developed a non-healing ulcer over right buccal mucosa, later developed trismus. He ignored the ulcer and trismus and hardly looks inside his own mouth. Habit of smoking 10 berries per day for the past 20 years, had occasionally punching habit with tobacco. Later, he developed an ulceration lesion over the skin of cheeks, starting at the angle of his mouth and spreading. This was followed by mixed nociceptive and neuropathic pain. Pain score was 9 by 10, and then no significant history of past medical illness or surgery, insomnia, and unable to follow to it. Next slide. Examination on inspection of the on external examination of the patient, relevant and ulcer proliferative growth of abnormal tissue cells on the right side of the face, angle of the mouth, and skin of cheeks. Upon intraocular examination, a large proliferative growth around 7 cm into 3 cm was seen in the right buccal mucosa involving the lower gingiva buccal, sulcus, and lower alveolus. Growth was not tender and non-palpable. The lesion was tender with mild intubation. Partial trismus was present. Neck nodules palpable. Next. Treatment and significant investigation. Bounce biopsy, a biopsy in which a small round sample of tissue with such as skin is obtained by using an instrument with a circular bend. MDSCC was found. Moderate differential squamous cell, which means tumor cell does not look like a normal, which can be termed as grade 2. CT scan, same thing in immunologic diseases. Blood investigation was normal. CXR, no metastasis, was planned for 30 grades in 10 fraction, palliative EBRT to the primary lesion and neck. He has received the first fraction. Next slide. Psychological aspect patient daily wages earner as a local factory farmer, family nuclear, and then patient was caregiver and unable to grasp the concept of incurable diseases, knowing the deficiencies, and then concerned about the financial and monthly obligation balancing treatment with the quality of life, less contact with family members and friends because of depression and fatigue, and then grief, sadness, and fear of taboo, loss of hopes and loved ones. Next. Family members experience vulnerability with the realization that they could have happened to themselves. Patient facing more physical disability as the disease progresses and treatment becomes more aggressive. Loss of faith in the medical establishment as the individual realized the initial treatment did not provide a cure. Guilt of not stopping tobacco in time. Next. Next slide. Medication. He was on codeine and paracetamol combination for pain with NSAIDs with pain score of 9 by 10. Tablet morphine sulfate IR 10 mg for hourly if necessary. Tablet metoclopramide 10 mg TDS prevention of nausea vomiting induced by chemotherapy and radiation. Tablet bisacodyl HS RX for constipation, and then syringe cremation plus. Tablet ibuprofen 400 mg TDS. Tablet paracetamol 650 mg TDS. Tablet amitriptyline 10 mg for major depression, and then tablet dexa for 4 mg OD for inflammation or allergic purpose. Tablet pentops for 4 mg OD. Clean dressing, oral care, color-exceeding mouthwashes, nasogastric tube insertion. Next slide. Main concern: patient and family has not understood in-depth knowledge regarding the course of treatment before starting the palliative radiation therapy, making the patient and caregiving aware of what to expect during and after radiation therapy. Now problems like mucositis and skin reaction, exacerbation of pain, weakness, nausea, and vomiting. Next slide. A 45-year-old male patient was admitted in NHK with the presenting complaint of all ulceration, trismus ulceration over skin of cheeks with disease, with discharge and unable to chew or eat. For the past 1 year, he was planned for cardiac arrest in the palliative EBRT to the primary lesion and neck. After through investigation, he was finally diagnosed with local advanced oral cancer, CT4B, and 2 or more. After the first meeting with the patient and family, it was clear to me that there is a failure to understand true prognosis. I also found out that the patient wife was not told about the incurability of the disease by the son. Over the next 2 meetings with the family and patient, there was in-depth discussion with the openness regarding the disease stages and prognosis, empowerment of son to take care of the physical problems. Next slide. Decision and learning points, providing in-depth knowledge regarding disease stages and prognosis, building a good report with the patient and family members for active communication, breaking back news diagnosis and prognosis, hospice and palliative care specialists and trained volunteers assist not only on the dying person but also caregiving and family members too, offering emotional support, including grief counseling and enabling the patient to live their final day with the high quality of life possibility, specifying that is coping strategies for the adverse possible side effect. Next slide. Thank you.
Thank you, Dr. Resi, for like you have gone through all the details, description, history, and everything. Thank you so much for the details and wonderful presentation. I think, Dr. Biju, this is a very often encountered situation where we think that, or we say that patient did not, or they come from a very illiterate background, or they don't understand. Sometimes even if we tell the diagnosis and prognosis, they may not understand what we mean. So how to go about it?
You tell me, Sridevi. You are a master at it yourself. Why should I be telling all the answers?
No, sir. No, sir.
What
You're
would you
the
do?
expert. Yeah. Should we ask any participant before I get into that scenario?
I think that's an excellent idea.
Yeah, yeah. Like many of you might be going through this, like patients come from, that's a very common statement that we hear from many of the sessions, that the patients were caregivers were illiterate. They did not understand, or they do not understand when we talk about cancer and other things. How do you usually go about it, or after the session, how do you think should we deal with the situation? Is there any comments anyone wants to share?
Ma'am, can I speak?
Yeah, yes, Dr. Shweta, please.
Ma'am, generally, it's not just for the people who are less educated or illiterate. Generally, even city side, patients don't generally know unless they have Googled about their condition previously. So I've come across a couple of similar situations, but the only thing is what I have generally tried to do is first try to ask the patient what do they know. It's very standard procedure. Follow that. Do they know what is wrong? And then I also ask them in the very beginning, is there anybody else who they would like to be present at the while we're discussing all these things. And then from there, depending on how they respond, try to talk to them in simple terms. Like I just saw it in the chat box right now. So in simple terms, like think like how they would understand. And then at every step, ask them questions. Whatever I'm speaking, I try to ask them again. Am I being clear? And if they respond accordingly, I again modify my, the information that I provide. But a lot of time, I do realize that there's a lot of, like, yes, apart from emotion, they don't want to talk about it in the initial stages. So at that first point, I just give the basic information, whatever basic they want to know. And then afterwards, I tell them to come back to me. And at many a times, I do feel like maybe a professional, counseling, this thing comes into, it might be very helpful. I usually feel that, because as a dentist, as a doctor, there is a limitation as to how much I can formally tell these patients. So I really find counseling somewhere might play a really important role in this.
Thank you, Dr. Shweta. And again, in the chat, Dr. Vanita has mentioned about simplifying things and slowly trying to explain. And you started with asking them, like exactly what Dr. Biju was talking about, like asking them what do they know, and start from there, like understand their story and proceed from their own story. Dr. Chaitanya, please.
Yeah, so I mean, in rural parts of India, what usually happens is that people would have loads of papers with which they would come to us, and mostly those would be advanced cancers. And I mean, I usually try and spend more time listening to their stories. And then there are 2 or 3 common scenarios that I've encountered. One is they would either have never heard the term cancer. So, and sometimes the second scenario is when they've heard the term cancer, they don't understand what would cancer at an advanced stage mean. And they would only associate things with their symptoms. So I usually go with their symptoms. I mean, if you're losing weight, why do you think that would be happening? So I would want to circumscribe it to, is it life-threatening, organ-threatening, or is it limiting their lifespan in a significant ways, which is much more relatable to the patients than the histopathological diagnosis that we go about usually explaining. And then the other thing that I try and commonly use is if it is an elderly in rural area, he or she would usually come with a younger attendant, because by now they're used to medical places not speaking jargon or speaking in ways where they may not be able to understand. So I try and get the family member also along, and sometimes that person has much more information than the patient himself or herself. And then I would talk to them, I mean, for longer than usual in a busy OPD to get to the bottom of these things. But these are challenges.
Excellent response, Dr. Chaitanya. And he works extensively in rural areas. He and his NGO, like they do extensive work in the very rural places in India. I like the concept how he put those things in a very simple way, like rather than focusing on conveying the word cancer or histopathology, like connecting it to what the patient understand and how it is relevant in his life, how cancer becomes relevant and the prognosis becomes relevant in his life. Very an excellent response. We would have missed that, Dr. Biju, if I asked you that question directly. And thank you, Dr. Shweta and Dr. Vanita, who responded in the chat. Sir, would you like to add on something else to the discussion from your side?
I think if we keep quiet, we will hear more gems like
Yes,
this.
sir. Yes.
Right? How Dr. Shweta and Dr. Chaitanya has brought out information. Only thing is probably the time is the only constraint now, because I think there are plenty of other people who are going to bring forth excellent responses like this. Only if we have time. Are we really short of time, Sridevi?
Can take a few minutes, definitely, because this is a very important, the most important topic. So we can listen to a few more if there are some
So,
responses.
just two things that I would bring. Yeah, Dr. Shrikant has something to say.
Yes, Dr. Shrikant.
I think I raised my hand prematurely. I'll wait to hear what you're saying, sir. Then
I think we are all more interested in what the delegates have to say. So it is like the classic Hindi picture situation, pehle aap. So,
I'll try to
but
finish
because
as
you
soon
are
as
more
I can.
important than us, me and Sridevi in the context. So please, I would urge you, please say what you have to say.
So I also work like Dr. Nidhi. She was my teacher at St. John's. Like her, I also work in neurological rehabilitation, where the lifespan of patients is not limited, but still they are faced with debilitating disease. So when you have somebody with spinal cord injury, post surgery, there is a you mostly will find patients who are paraplegic, bedbound, and with indwelling catheter and a developing pressure ulcer, and with limited resources to manage what's going to happen next, and with a lifelong of possibly ambulating with knee, ankle, foot orthosis, might need a wheelchair and specific training to manage their ADLs, and might need clean intermittent catheterization and specific bowel management program. To be able to tell all of that at one sitting is difficult. So what we usually do is we break it into bits to sort of convey information during the inpatient program in stages, so that they are more ready to prepare. Once they take care of their bed mobility, once they understand how their body feels, we sort of ease into the information, and we use sometimes. So my teacher has asked us to use diagrams pictorially to explain how the kidneys work, and tell them why it's important. For example, for neurogenic bladder, we would say that if there is dirty water collected in the pipe, it will reflux back and cause damage to the kidneys, and then slowly ease into the reasons why they need to do CIC, and not take too much time, but still not overwhelm them with information at the first sitting, but take a few sessions to convey. I think this is what I just wanted to convey.
Again, excellent point. I have seen or heard Dr. Biju using pictorial depiction of so many, like pain, the cachexia, feeding issues, and that, as Dr. Shrikant, you said, like easing into that, giving in bits and pictorial representation works really well for many patients, like for almost all the symptoms. Sir, we have Dr. Dheeraj raising his hand. Yes, Dr. Dheeraj.
Yeah, I'm understanding how to break this bad news to elderly patients or adult patients. I have two kids who comes to our OPD and have a spinocerebellar degeneration. One is 6 years old and another is 4-year-olds. And we know that their prognosis is bad. And for adult, it may be difficult. How are we going to how are we are going to break this bad news to those children? Will they be able to understand what they are going to face? That's a difficult.
Yeah, thank you, Dr. Dhiraj, for that question. Communicating bad news to anybody is hard enough. Communicating bad news to children is perhaps the biggest challenge that we would come across. And for that, we have to understand there is a structure to that as well. We are not covering this here, but how you communicate bad news to children is little different from adults, because a child's psychological development of their understanding of the world is different from an adult. So, for example, if it is a terminally ill baby, we would encourage the parents to give more of a skin-to-skin contact as part of comforting. How you deal with uh, a child who is 3, 4, 5 years old, because their abstract thinking would not have developed. For them, that may be just going somewhere and coming, and there is always this thing about coming back. Heaven and hell concepts may be more like going to the park, something that they can relate. So how you convey or talk about death and dying would, for a with a 4-year-old, would be very different from how you would be talking to a 7, 8-year-old. And that will be very different how you would be talking to a 12 or a 13-year-old. When we say teenagers, we are not talking about 13, which is technically the time teen starts. But we know that sometimes even 12-year-old are teenagers psychologically. And how you deal with a teenager would be almost akin to how you would deal with an adult, because they would be offended if you deal with them as a child. So when it comes to communicating bad news with children, we have to keep in mind their age group and communicate appropriately. And that is possible. It is not an impossible part. It is a very structured way of dealing with it. It is age-specific discussion of truth-telling. Essentially, it is truth-telling in a way, just like in adults, we say, keep it simple so that people understand. Similarly, keep it child age appropriate so that they understand what's it about. And usually who deal with pediatric palliative care professionals who deal with this and are dealing with talking to children, conveying truth, telling with children, general feedback is children are usually very insightful about what is happening to them, and perhaps equally, if not more resilient than adults. Sridevi, with your permission, if I may add one or two points, because we're really overshooting time.
Sure, sir. Sure.
I hope the question, it was not very, very satisfactory, but I hope it is okay for the time being for Dr. Dhiraj. I hope so. Moving forward, there was this thing about the educational status of a patient when it comes to understanding what the how you communicate. Let me assure you that education per se does not determine people's ability to understand. I have had people who are highly educated, professionally qualified, engineers, lawyers, chartered accountants, and people at very high position, politicians who have seen the world, but they don't understand the medical things. And it is not surprising because it is a different area. So you can have highly educated, highly qualified people, but totally agnostic about medical situations, just like you will have people who are illiterate who don't understand. But whether you're illiterate or highly educated, you are a human being and you understand the basic things about our life. For example, I'll give you an example. If we make it clear, people understand. If we don't make it clear, people don't understand. Once, while I was working in Palem India, we had an experience. There was one patient who was referred from another hospital, and the patient was brought in, and we found that the patient was gasping. And we asked, because now this was something that we are seeing for the first time, this patient and the family, we don't know anything about them. We just had a reference letter. The reference letter was pretty clear. And we asked them, what did they tell you from the referring place? So they said that it was serious. And we asked them, so what exactly do you understand that about being serious? He said that he's serious, and then we came here to get better treatment, so he's going to get better. So according to them, the word serious means that he's going to get better after coming to us. From the place where they were referred, they mentioned he's serious because this chap is going to die. So what we convey, if it is not clear, they will not understand. And how do you make it clear? You have to use words which are beyond doubt. We told the family, he is dying. So they were surprised, but they never told us. They said he's only serious, right? So we have to stop being uncomfortable. Of course, it is uncomfortable, but the more you use word like this is cancer, don't use words like it is that disease. You know, so you have to be clear. It is cancer. This your loved one is in the process of dying, or he or she is dying, or death is nearby. So the more you practice using the words, you become less uncomfortable. That does not mean you become less sensitive. You have to use your body language, the tone of your voice, which conveys your sensitivity and empathy, but you have to use words with clarity. There is no other way about going it. You use the words, the exact words that you want to convey, not an not an analogy, then the exact word will convey the exact meaning. That is something that we have to learn and practice. And the last thing that I want to say is I see a lot of compliments in the chat box, and that lifts my spirit, because when you appreciate me, I feel happy about having made an effort to prepare this presentation and come and spend this time with you. It motivates me to do this more. So thank you, each one of you, for that. My gratitude. Also, make it a habit to compliment one person at least once a day, because all this positive energy that you will generate will create more positive energy inside you and around you. Always give one compliment at least to one person a day, minimum. So with that, I think I'll stop here. if there are still any more questions, I'll be still happy to take them. Otherwise, Sridevi.
Sir, I just want one minute. I just
Yes,
want
yes, Dr.
to
Shetty.
say
Yes.
thank you, because your topic on anger management is not
Yes,
only
please.
good for patients for day-to-day life, family life also. I think that's the best way.
Yeah, this standard operating procedure for anger management works, and it is easy skill to master, and it often prevents. You might have seen a lot of WhatsApp videos and all when doctors are getting beaten up, and if you
Yeah,
look at
yeah,
the
sure.
initial part of it, you will see usually the doctor is sitting and arguing with the person in there. So there are a lot of things that we can do to get
Definitely,
these things
definitely.
sorted out.
It is that's a nice segment, like a nice session you have.
Thank you so much. Okay.
Thank you, Dr. Biju, as for the wonderful session and the interaction. Thank you all the participants for bringing in a lot of good points, excellent points.
Yes.
So I was thinking in the background that so there are people who are interested to talk to patients, to learn more, to polish their communication skills. So that's a wonderful thing to understand also. So thank you so much for the interaction as always during all the sessions. Thank you, Dr. Biju, again for the time and today's session. Sri Priya?
Thank you, Dr. Biju Raghavan. As usual, we could have been like disappointed if it was something less. Every time it goes on increasing the positivity, the knowledge, and all. So even for they being the first timers, but me and Sridevi ma'am, we have been listening this maybe couple of times now, but still we get at least 1 point to learn from each session. Thank you so much for that, and please do take that as a compliment, so that I can also go back home with that positivity. So I did my
Thank
part
you
for
so
the
much,
day.
Thank you
So,
so much. So sweet of you. Thank you.
pleasure is
So,
ours, because we do understand your busy schedule. So with that positive note, this is Sri Priya along with Dr. Biju Raghavan and Dr. Sridevi Warrior signing off from the Tips Eco Hub. Take care, everyone. See you in the next session with another interesting topic and an eminent faculty. Bye-bye.